Other diagnostics we can do is CAT scans. It's going to look for bleeding areas, tumors, if there's a chest X-ray. Actually, a CT will show fractured ribs beautifully, especially with anybody who has a trauma. And then the other big one we do is a thoracentesis. And this is usually when we have a fluid collecting in the pleural space in the lower lobe, way down here. And depending on how much fluid, they might just go in and drain it, or they might put in a tube for continual drainage if it's a lot. Because like I said, this fluid here is pushing up on the lung tissue. And it's going to cause the alveoli in that area to collapse because they can't expand because they're being pressed on. Now, to do this is consentable again. It's informed consent. We have to explain the procedure because up on the floors, they do it right at the bedside. They'll have the person sit upright, open, usually on the side of the bed, with their hands in front of them, a lean over their bed table. Okay? And the doc will come from behind. They're going to actually give a sedative. They're going to give a numbing agent, probably lidocaine, in the area before they poke the needle in there. Okay, and then what they're going to do is they're going to draw out the fluid. All right, we don't want the patient to cough or talk during this whole procedure because it can move the needle and we can possibly puncture the lung. But as a nurse, you will be standing there observing your patient for hypoxia, if they're starting to go cyanotic on you. And then when it's done, we want to reassess our lung sounds and see if the lung sounds have been reestablished in the area. And because it's going in there with a big needle, there is the possibility of puncturing a lung. They always have to have a chest X-ray after the procedure. Now, if they can't sit up on the side of the bed, what we do is roll them on a lateral position with the affected side upward. But we do have to rule out the normal pneumothorax. And this is kind of how we do it, okay? So this woman has a lot of fluid in here that's got to come out. And so he goes in with the needle, and then he's going to attach it to a drainage bag because there's so much, we're going to just continually be draining. Otherwise, he can go in there with a large syringe, just suck out what he wants, if he thinks he's got it all, and then stop. And then just put a Band-Aid over the hole. But that's what they look like. Other diagnostics we can use, sputum cultures. Oh, big one, tells us a lot of stuff. It needs to be early in the morning. You're going to have them spit up into a sterile cup. And we definitely want to get any kind of cultures before we start antibiotics. Because we need to identify what organism it is. And if we've already started on the antibiotics, it's not going to be accurate. So if we're going to get sputum cultures, it has to be before they go on antibiotics. The other thing we're going to do is ABGs. Of course, it's going to be an arterial stick. It's either going to be in the radial, most of the time it's the radial, but we can do brachial and we can do femoral. It's going to go in the artery. All right? Now, the one big thing is if we're going to do an ABG and this patient's on oxygen, we don't want to change the oxygen concentration for at least 20 minutes before we do this gas, because it's going to alter the gas also. We want to let the patient equilibrate on the oxygen before we get a blood gas. Okay? And of course, it's just a little syringe. Most patients say in the radial artery it hurts like heck. They say it hurts a lot less if you go brachially, but what do I know? I've never had one. But then it's got to directly go on ice because otherwise the oxygen is going to start leaching out of the blood. So we got to get it immediately on ice and it has to go immediately to the blood gas lab. Other things we can do are skin tests. Most people, anybody with allergies, I'm sure has had skin tests. And nowadays I found out we don't have to do scratch tests. They just leach you for about 6 tubes of blood and they can analyze your blood and tell you what you're allergic to. I was like floored. We can do lung biopsies. That's going to tell us what we might need to know. MRIs are going to tell us if there's a vascular versus a non-vascular lesion. And then we can do ventilation perfusion scans. These are called VQ scans. All right? And it's basically a lung scan where we're going to, that's going to assess our ventilation and our perfusion. How well are we delivering enough oxygen to the alveoli, number one, and is there enough alveoli to perform gas exchange? That's the VQ. Okay, so we're going to put a radioactive tracer into, they're going to shoot up some radioactive tracer and then just take a bunch of x-rays out their chest while they're breathing. The next biggest is pulmonary function tests, PFTs. Anybody that has allergies, I've probably done a PFT. Okay, basically it's measuring our compliance and our resistance of our lungs, the compliance and resistance of our lungs. And it's going to tell us if we have an obstructive or a restrictive defect. All right? Now, the thing is, before they do the PFT test, you cannot use your bronchodilators. All right? Because otherwise it will be a false test. So if they're on bronchodilators, they have to hold them before the test. Okay, and then they'll have you breathe into this little machine. It was kind of neat because when I went to my allergist here in Gainesville, every time I go, I have to do a PFT test. And his was a birthday cake on a computer screen. And the candles were lit. And we had to blow into the thing and blow out all those fake candles on the screen. And that's how he would measure the compliance. Now they have bigger and better machines nowadays. But not only that, after they do it without the bronchodilator, they have you take your bronchodilator, and then you just sit there for a little bit while it starts working, and then they repeat the test to see how effective the bronchodilator is. Okay? It's also going to tell us if we need to put somebody on a ventilator. Because if we're not getting anywhere and there's no tidal volume on this PFT test, which is the amount you breathe in, they're going to need to be ventilated. Another little thing we do is pulse oximetry. You're doing this up on the floor with your patients every time you do vital time. It's going to measure the percentage of hemoglobin saturated with oxygen. All right? And it's done with a little infrared thing. And usually we put it on the fingers, but I hate to say it, if they're cold, the finger is not going to give you an accurate saturation. We can actually put it on the forehead, and we can also put it on the ear, and we can also put it just below the patella. And we will get our waveform that we want so we can get a saturation. Now, normal SpO2, which is partial pressure of oxygen, it's telling us how much oxygen is available in the alveoli, is about 95 to 100%. But that's what we're measuring because you're breathing in and out. The saturation, though, which you would get off your blood gas, your SaO2, should only be a 2 to 5% difference from our SpO2. If it's different, there's something going on, and it needs to be evaluated by the physicians. And lastly, this is the third time today you've asked to go up for a breath. Okay, everybody go take your break, because then we're going to go into the wonderful world of pneumonia.
Oh my God. No, I just. Yes, I'm sure.
computer and the computer writes for her. Really? Yes. She told me how to do it. I wonder how well that. Back on top. You can master on this. Yeah. So you don't record? No. You don't have slide? You only have enough? And that's why you say? Holy shit. Yeah. I mean, it's really impressive. I've never seen how you do that. Why open water? I like compare the stuff and write both this and this in the flashcard, but you remember a lot of stuff sometimes. You absorb a lot while you're here. Yeah. That's helpful. And I tried recording. I listened to it for like 5 minutes and then I was like, no. Yeah. It's really time consuming. I have to go back and listen to the whole lecture. So that's what I'll do, and then I'll like stop it. Right. Continue like it's longer than lecture time. Because I'm doing that. Yeah, kind of. I want to be able to do that. I wonder if those people from... Is that all you? Oh.
Oh God, I could be you so much.
I didn't know there's anybody coming over.
He wants to know your name.
He's so angry. Wait, is that yours? It's green. But isn't that?
Because they'll charge it too.
Doesn't it take the information?
Because it's super cute.
Not the community city office.
Oh, you didn't hear it?
Oh, that
No.
sucks.
Eddie doesn't drink up to your kid.
They have to be closed because they're going to keep an eye on it.
Is it your iPad? That's the last one. You know how much? Is yours like dead? Or is it? Yeah, it's like an 80%. Yeah, it's like 80% something.
Yeah, I mean, I'm sure somebody will be fine. You know what I mean? They'll understand. Or they won't notice.
I can make it.
Tell him to make me a beat for you.
I get like brown. Like I get home to my parents and I feel like, where are your parents?
You know what? You're those kind of girls that you have to you work out every morning and you're not.
Does she? I think so.
Go back home. See you, buddy.
Have you caught your breath yet? Are you sure you didn't go by bicycle or something? Holy moly.
Yolanda! Babe.
Okay, you're good. All right. So now what we're going to do is we're going to talk a little bit. Oh, well, I could have done that. I can push any button. Just don't tell me how to set it up. We're going to talk about pneumonia. That's what I call pneumonia. That's the only way I know how to spell it appropriately. And if you look at these x-rays, here's a normal one, okay? It's nice and dark. Looks good. Look at this one. Okay, this lung is pretty clear. But look at this lung. The bottoms of it is gone. Which tells us either there's consolidation or there's fluid in there. Okay? Now, number one, all pneumonia is an inflammation of the lung parenchyma. That's all it is. Okay? Now, up until 63, it was 1963, which most of you, your parents weren't even thinking about you then. Now that I think about it, my mother wasn't thinking about me either. Oh well. Up until 36, it was the leading cause of death. Okay? It was the leading cause of death in the United States. And then all of a sudden, we discovered the sulfa drugs and the penicillin, of which I don't know what's about. So they're not the pneumonia. But then we found, but sulfa and penicillin seem to help the whole healing process. I knew I forgot to do something. Let's see who this is, which friend this is now. Idaho. Go away. Idaho. Okay. Anyway, so we discovered sulfa and penicillin, but you know what's so scary about it? Even with the antibiotics, it is still the 5th leading cause of death in the U.S. That's scary. Okay? And it's really, more than anything, it takes the very young and the very old. Because both of them, their defenses are not as strong as when you are an adult. They can't fight it off. Now, like I said, think about it this way. The airway distal to the trachea, which is your bronchioles all the way down your alveoli, is considered sterile. And it's due to all our little protective mechanisms, right? Our air filtration, warming, humidification, glottal closures, cough, reflex, escalator, and our little scrubbing bubbles. So it is considered sterile. That is one of the reasons why when we suction somebody, we do it sterilely. Okay? But what's in real fact, you're never going to get down that far to invade the sterile place with the suction catheter. You're never going to get down that far. All right? But we have these mechanisms to keep our lungs clean and sterile. Now, what kind of variables would cause a problem? First, psychological variables. Patients with lack of education are probably going to get it. Patients with dementia. Patients with Alzheimer's. These are the type of patients that will possibly get a pneumonia. Socioculturally, occupational things, the guys that work in the coal mines. Okay, people that was working around asbestos were very prone to coming down with pneumonia. Lifestyle, people that have poor eating habits, they're not getting appropriate nutrition. Patients with alcoholism, drug abuse. And then health habits, dirty houses, like hoarders' houses, okay? Key people, there are people still out there who do not have heating and cooling in their houses, okay? People with poor immune systems, people with general disability, people, and there's still places out there with lack of sanitation. So health habits are going to be a variable that can cause you to be predisposed to going and having pneumonia. Now, other things when it comes to patients with decreased level of consciousness or loss of gag and cough reflexes, they're prone. Anybody that is tracheally intubated to be put on a ventilator because they're taking a tube right down there. Pollution, smoking, environmental chemicals. I wouldn't want to live in LA. I also wouldn't want to live in China. They all walk around with masks on. There's so much stuff going on in the air. Okay? So, and the pollution is only getting worse. People with upper respiratory tract infections, because what can happen is the upper respiratory infection can migrate down to the lower lobes and cause pneumonia. Did I hear what I really thought I heard? Okay. The aging process, because sometimes as people get older, they are having an issue with complete glottal closure. So they have defective swallowing. And that's when we have to do swallow studies on patients. Okay? Malnutrition, certain disease processes, and traumas can cause predisposition to trauma especially. And then the overuse of antibiotics. They're saying by 2020 we'll be out of antibiotics completely. It's also one of the reasons why we are getting more drug-resistant diseases, because we have abused and misused antibiotics for so long. And pharmaceutical companies aren't going to make any more antibiotics because what they want to make their money is they want people that are stuck on taking a pill 7 days a week and for the rest of their life. They don't want somebody to just take their pills for 7 days and then call it quits. We're not making any money. Now, next process, how do we get pneumonia? Well, that's pretty easy. We can aspirate. Nasopharynx, oropharynx aspiration, and gastric aspiration. All right? Other thing we can do is inhale it out of the air. Microbes that are floating around in our air. Hematogenesis, where it's spreading from one area to another, like a staph infection. Direct inoculation. Now, it's funny because for years I would not take the flu shot because one and the only time I did take it, I came down with the flu. So I didn't take it anymore. But yes, they said, no, you can't get flu from taking the flu shot. Well, don't tell me you can't. Okay, but direct inoculation. And then migration. So we can get it in a variety of ways. Now, one of the types that we've got to talk about is community-acquired pneumonia. This is things like Legionella, strep pneumonia, respiratory viruses. Okay, you get it in the community. That's why I hate winter around here, because when one of you starts coughing, y'all start coughing. But you're just spreading it all over. You're spreading the world. All over the place. You're just spreading the world. Okay? Now, approximately 1.5 million people are hospitalized with pneumonia. Now we're on pneumonia. Hospitalized every year. 6.5 million of us get a pneumonia annually. All right? 900,000 of us die, and like I said, it's old and young. Okay? course, we know the winter months are the peak months of this whole thing. That's when it gets really nasty. And usually, what do I do now? Oh, for God's sakes, dear. All right, you now had your lecture. Oh my God, I'm having a riot. I need to go home. You will learn, though, that 2 o'clock is my bewitching hour. I'm already hearing my lazy boy calling from Reddick. What's up?
What is migration?
Migration is like, say you have an infected cut here, and you're messing with it and everything else, and then you go up here and you put your fingers in your mouth. It's migrating from one area to the next.
And how is that different than the management?
Because that's already internal. It's internal.
Internal or hematogenesis?
Hematogenesis is internal.
So it spreads from one area to another internally, and migration is from one area to another externally.
Okay, so back to community acquired. Okay, so it peaks in the winter months. Now, the problem we have found, remember, one thing you got to remember, you're going into a career to work in the germiest place on earth. The hospital has more germs in it than you could ever find. Matter of fact, I'm one of these people where I have a special pair of sneakers just for the hospital, and they come off outside before I walk in the house. My clothes immediately go in the washer by themselves. Okay? Because every germ you can think of is in this facility that you will function in. Alright? So it's very easy. So lots of times they have found that patients come in that are coming in already debilitated with a problem wind up coming down with pneumonia in about 2 days of hospitalization. So there has now been a big push that if the person is even susceptible to possibly coming down with it, they want to have antibiotics started within 4 hours of hospital admission. They're getting real proactive. Because if they come down with pneumonia, the length of stay is going to be extended, and it's not going to look good for the hospital because they're taking up a bed when I need somebody else to have that bed. Okay, kind of thing? So they're now being proactive. If they suspect that you're going to come down with pneumonia, they'll start antibiotics within 4 hours of admission.
So won't you get resistance?
Huh?
Won't you get resistance? And you're trying to prevent it.
No, because what they're going to do is they're going to immediately get the sputum samples, and then they're going to start the antibiotics.
Is that considered the abuse and misuse of antibiotics if they don't have an infection yet?
To an extent it is. But I mean, think about it. Antibiotics are only good for viruses. Our colds are mostly bacterial. And here we're all taking antibiotics. Right? If that's kind of misuse and abuse that we've been using. Doctors said, if you even say, I got a hangnail, they'll put you on an antibiotic. Okay, now that's slowing down. But like I said, we're going to be out of antibiotics by 2020. That's the scary part. And that's also the reason why at this point we've had so many diseases mutate, they have become drug resistant. That's why we have MRSA. That's why we have VRE. You know, that's why we, actually when we get to it, that is why we have drug resistant TB. Okay? Now, hospital-acquired pneumonia, this is the worst that can happen here because it goes on the hospital's little ring-eating. 0.5 to 5% of hospital patients are going to come down with pneumonia. All right? And like I said, it occurs after the first 48 hours of the admission. Now, if they're intubated, it goes up by 6 to 20% chance that they're going to get it. It has the highest mortality. And like I said, because they acquired it in the hospital, that's where the term nosocomial comes from. It was hospital acquired. Now, and it's things like Pseudomonas, Enterobacter. We have another thing called VAP, ventilator-associated pneumonia. These are our staph and our strep infections. Okay, that's what all these are. And they can come from microaspiration from our upper airways, where we take it down lower, or macro aspiration of gastric contents, where we go to throw up, and instead of coming out, it goes down our lungs. And of course, anybody that is immunosuppressed, or very debilitated, are going to be definitely prone for it. So like I said, we're becoming more proactive. And then we got aspiration pneumonia. And this is the patient that loses consciousness for a period of time. And if your patient loses consciousness, you never want to lay them flat on their back. You want to turn them on their lateral side. So if they do throw up, it doesn't go down in their lungs. Anybody with a loss of consciousness, you want on their side. Anybody that's seizing, always on their side. Okay? Anybody that's getting tube feedings. If they're getting tube feedings, the head of the bed should be up at 30 degrees at all times. And if you do have to lay them flat to either roll them or change the bed or whatever, you need to stop the feeding while you're doing it until you can get them back in an upright position to be started again. Anybody under anesthesia is very susceptible to aspiration. Okay? Our traumatic head injuries. People with stroke, because they may be having a swallow problem. Extensive alcohol intake. Okay, extensive alcohol intake. And anybody with a loss of gag or cough reflexes. These are people are all prone to possibly bronchiolic pneumonia, aspiration pneumonia.
Would you say the increased alcohol intake, would that be because related to decreasing physical consciousness?
That's why I'm saying it's excessive.
Right.
You know what I'm saying? Anybody, anybody that has a little bit overindulged, what do they usually do?
It's like an acute thing.
Mm-hmm. Yeah. Now, then we have a thing called opportunistic pneumonia. These are people, anybody with altered immune systems or immunosuppressed, and that's due to cyclosporin and Prograf and all sorts of stuff to knock their immune system out. Anybody that is malnourished is at risk for this. And this is where the pneumonia just says, oh, I see a little weak duckling over here, I'm going to go after him. Okay? Anybody that's on radiation or chemotherapy or both. Anybody with bone marrow depression are prone for an opportunistic pneumonia. And 70%, this is a startling, 70% of HIV patients come down with pneumonia, and it's called pneumocystis. And on X-ray, it looks like a bunch of little grape clusters all throughout the lung fields. And I've seen it only once, and it was like very striking to see. Okay? And then people who have CMV, which is a viral problem, it's called cytomegalovirus. Number one, it is a member of the herpes virus group. And it usually develops in the fetus, transmitted to the fetus from the mother, but also transplant patients are very susceptible to CMV. Now, pneumonia has four very distinctive stages, okay? First comes the congestion stage, all right? And that's where fluid starts pouring into the alveoli. Now, think about this. Down in your lungs, you're going to have fluid, right? It's dark, it's damp, and it's warm. Great petri dish for growing organisms. Okay, great petri dish. Okay, so all this fluid starts going into the filling up the alveoli. So all of a sudden now, there's fluid in the alveoli, so there's no gas exchange. Then we enter what we call red hepatitization. And this now is where capillaries start dilating, white cells, neutrophils, red blood cells, fibrins start flowing into the alveoli. All right? Over a period of time, we go into gray hepatization, where this blood flow going into the alveoli ceases. And what happens is the white blood cells and fibers start consolidating in the affected area. So it's not widespread anymore. It is more condensed area, to a more condensed area. And then eventually we get to resolution. Now, how long this takes? Totally dependent upon the patient. If they have other things going on with them, it might take longer. If they're physically fit, it will be a shorter course, but it's got to run the whole course. Okay? Now, in the beginning, you might not have any issues with signs and symptoms. None. But usually what you're going to start seeing is a sudden onset of fever and chills. Okay? Number 2, they're going to start coughing. And it's going to start producing productive sputum. And it could be actually purulent. But think of it this way. The sputum colors of the rainbow that usually indicate pneumonia are yellow, green, and gray. You start seeing yellow sputum or green sputum, you're probably coming down with pneumonia. Now, with all this coughing, they're going to have pleuritic pain. They're going to have chest pain because they're coughing so hard. And this pleuritic pain can be moderate to severe. But like I said, we have to distinguish that chest pain, that it is pleuritic versus cardiac. Of course, when all this fluid is going into